So I'm Marvin Malek. I'm one of the preceptors in the Northern New England PNHP Health Policy Internship Program. And my task right now is to do a more economic analysis of uh, state-based reforms. Um, However, having said that, I do think that politically, there is a problem that in general, people advocating for state-based reform um, need to be aware of, given the transformation of the opposition movement against single payer reform in any iteration, whether it's national or state. And that is that we now have um, a, a political party that is pretty ideologically married to regarding government as harmful, and that government can actually be dismantled with no apparent ill effect, or at least that seems to be the predicate for what we've been observing since January of this year. So the willingness to just take down programs, I mean, you could mention almost any of them. The low income heat assistance program is now pretty much gone. Very poor people freezing in their homes in the northern United States or boiling in their homes in southern Florida or in Arizona. I mean, this this is unprecedented that you can't even do the least for the most unfortunate people in society. And the and it strikes me as very much ideologically driven. And I now feel that a piece that with the current power structure we're seeing in the current version of the modern Republican Party, this iteration, that they would actively work to undermine any state that dared to deviate from this kind of free market or free market orientation, or just simply anti-government. So I think from my point of view, that's an additional political obstacle to the success of a state-based attempt at trying to extricate itself in a more humane way from the U.S. healthcare system. However, the purpose of this talk is to actually do a more economic and kind of policy-based uh, a look at that type of reform. And this afternoon, you'll be able to hear some advocates for state-based reform. And I would like you to keep the array of issues that I'm going to bring up, that keep them in your mind when you hear of people who are advocating in favor of state-based reform, and ask yourself, are they addressing the kind of annoying little problems? And I just want to say, as I'm pointing out the problems I have with state-based reform, I'm not happy about it. I'm unhappy about it. I wish that state-based reform, that I could say with confidence that state-based reform could serve as a model for the country, and other states could then follow it, and inevitably would. And that we can imitate what happened in Canada between 1947 and 1971, that you'll learn more about tomorrow. But I fear something quite the opposite. I fear that the plan would collapse for economic reasons, financial reasons and economic reasons, even aside from the fact that I think the current president may simply squash it like a bug if it did start to work, because that seems to be a sort of this anti-government program approach or ideology that we're seeing from Washington. So let me go on with this type of analysis. And as ever, I do have some slides, and I will try to bring them up. Okay, so um, So, what are the obstacles to extricating for a state to extricate itself from the US healthcare system? And I guess if I can, there we go. So here's a cartoon that depicts a skeleton and presumably a person who had been a patient at a medical practice who's been waiting for healthcare reform so long that the person is now dead. And there he is, still patiently waiting, and it just never happens. Year after year goes by. And I think that this uh, reflects the impatience that those of us who've been in the movement for so many years. When I was in I was in medical school like in the Cretaceous era by modern standards. And back then, I've been actually a single payer activist, from the time I was in medical school. So yeah, I'm pretty sad and disappointed that so little has been accomplished. And in terms of the infrastructure ownership part of it, things are now worse, and from my point of view, than they were. So I'm impatient too, and I'm sympathetic with people who are. But notwithstanding all the dysfunctions we've seen and discussed during this internship, I don't want to transform our system into something that will fail. I don't want to advocate for a proposal that I don't think will work and that I believe will collapse. And far from serving as a role model that other states could follow, my worry is that the program will collapse and be actively harmful to future efforts to enact meaningful reform in the United States. So Claire said earlier that she wasn't really opposed to it. It wasn't her work. She didn't relate to working for state-based reform and had some concerns about liberating more anti-government states to even deconstruct what they have. And in that regard, certainly it was very disturbing when states wouldn't take the Medicaid expansion money, which was free for the first 3 years. So the anti-government ideology is very strong in many states and could serve to undermine the healthcare system. But my concern is primarily that what proposals to replace it will replace it with something that will fail and serve as a cautionary tale so that other states will not want to go on that path. And here are the problems with it. The first issue is that there will be a tax increase because the available money will need to come from taxpayers. Some of the money that could be used to organize a state-based system. And so in other words, there's two sources of money to fund a state-based system. One is the tax increases, and the other is whatever other money you can bring into the system through other sources other than just raising taxes in your own state. So that's the big gestalt: taxes and everything else. And the everything else is really important because the magnitude of the tax increase, even if we had success at all the other at getting all the other money that you can try to make available for such a program, that the tax increase is very substantial. And the tax increase, for example, would double the taxation rate in Vermont for Vermont's proposal. And so you're asking many people who already feel they pay high taxes to pay a whole lot more into the state government. Now, you then immediately make the argument, well, this is a great program. You're getting rid of insurance premiums. You're getting rid of all these copays and deductibles. You're going to have great care. There's really not a problem. But you got to remember the people start out pretty skeptical. And you also have to remember, as we discussed last week, there are people who generally are healthy and higher income who will pay more to a considerable degree than under a state-based system than they would have under a federal system. I'm sorry, than they would have in the existing system. And I want you to also keep in mind that if you hear the argument that 90% of people will be better off with this reform, and it's only the 10% of the wealthy that will be worse off, that's speaking of the 10% as a whole. But you only know that at the end of the year when they didn't get sick. And if you look at the data, that a lot of the people in the second most wealthy group, in the third most wealthy group, some of them got sick that year. A small portion got sick and generated huge medical costs. And they certainly would have been better off with a system that was going to provide the fabulous coverage that these state-based systems invariably propose. But the other people in that decile group who are healthy generally are going to pay a whole lot more. So in other words, as a group, the second most wealthy 10% might be somewhat better off, but most of the individuals in that group, if they remain healthy throughout the year, they actually are financially worse off. And unfortunately, when you're advocating for all of these reform proposals that get rid of the copays and coinsurance and get rid of deductibles, many people have unrealistic views of their own vulnerability to become sick or getting themselves injured. When they go up the ladder to clean their gutter, they didn't think they were going to fall down and generate thousands of dollars worth of medical and neurosurgical expense, whatever happens to them. So it's an unfortunate thing that to try to engage people who have very optimistic views and unrealistic views that they are invulnerable. But here's a chart. This slide discusses the fact that a taxpayer making $200,000 a year who's currently paying a $4,000 a year premium is paying a very small portion of their income to get paying the employee share of their work-based insurance, whereas a lower paid employee who's only earning $20,000 a year, for that person, $4,000 a year is just a whole lot of money. So all of the single payer proposals are generally progressive, or at the very least flat and generally progressive. And you can see that in this progressive proposal, the wealthier taxpayers is paying just a whole lot more. And I personally agree that that's what ought to happen. But the question is, will that be acceptable to the wealthy people in your state? And I'm going to start now discussing the external source, other sources of funds that could mitigate the size of the tax increase in the state. And I'm going to start out by looking at Obamacare and the variety of taxes that the Obamacare plan used to generate income so that it could not unbalance the budget. In other words, Obamacare actually was not harmful to the federal budget, not because it was an efficient program itself. It didn't reduce administrative costs. It actually added to them. And they made little effort to reduce prices, which are the two big problems in the United States. But instead, here's what it did. It added a 3.8% tax on unearned income, which is basically capital gains for investors and interest, supplemental payroll tax on high-income taxpayers, extra corporate tax levy on corporations with employees earning more than $1 million a year, excise tax on medical device manufacturers, pharmaceutical companies, health insurance companies, and a tax penalty on large employers who aren't providing coverage. So basically, they taxed the wealthy to fund Obamacare, and that's what prevented it from being a deficit. They didn't make our healthcare system more efficient. They tapped the wealthy. And I've highlighted in red the taxes that are not going to be available to a state that wants to implement a state-based plan. You can't, you're not going to get away with taxing the medical device manufacturers or large pharma companies. It's just unrealistic and can't be done. So you can tax your own high-income taxpayers, and they most certainly would, and that's what's in all the proposals. And here's the national single payer bill, and here's another tax that cannot be used, which is, as I already said, my favorite tax, which is taxing stock and bond transactions for people who are constantly buying and selling stocks. That if they held the stock for years and years, they wouldn't have to pay this. But these people who are gaming the market and doing a lot of trading, day-to-day trading, they would pay a transaction fee each time. But a state-based system can't do that. So you've got a variety of taxes that could be available to a national plan and are proposed that cannot be taken advantage of at the state level. So now we've lost one potential source of revenue that's going to mitigate the state's tax increase, which is my goal. If I were working on a state-based program, that's what I want to do, mitigate the tax increase. Now, the next question is, are rich people going to want to pay more? And the answer is most of the time, yes, if it's not too much more. But Norway tried out a really big increase. They created a country's wealth tax and put it up to 1.1%, which for wealthy people can be a whole lot of money. Imagine if you put a 1.1% tax on Elon Musk's billions. I mean, that would be the largest tax ever paid by far. It would be 10 or 20 or $30 million each year. So there were warnings to the Progressive Party that instituted that tax, that capital flight could occur, and it did. They lost a whole lot of revenue. More super rich Norwegians left Norway in 2022, the year after this was implemented, than during the previous 13 years combined. So that was not good for Norway. But in general, rich people scarf away their money into tax havens across the globe, places like, Bermuda, the Cayman Islands that nobody's ever heard of. And their money goes there into these tax shelters with the sole goal of avoiding paying taxes in the United States. And this is a real problem. And this is why Luxembourg is one of the wealthiest, and Ireland, they're two of the wealthiest countries in Europe. I think they are the two wealthiest countries in Europe, only because they've got all this foreign capital that they, I guess, take a tiny portion of, but not as much as would get taxed in the United States. So anyway, there's the desire of rich people to avoid paying taxes, despite the fact that they can afford it. Will Elon Musk really be worse off if he paid $20 million a year of tax? I don't think so. I think he'd be just fine. But I'm not them, and this is what they do. So we have to live with this and contend with it. So I worry about the wealthy, happily, contributing this much greater amount of money that the states would want to tax. And in another example, the football team I follow, I'm from Buffalo, so I love the Bills, but teams being really greedy. They want the new stadium they think should be built. They want it completely funded by taxpayer money. This is what the wealthy corporations do instead of wanting to pay their fair share. So the question is, here they are, rich people at the Kentucky Derby, God knows, what they pay to get in there and whatever. Anyway, can they be relied on to stay and pay when they could simply move to another state? In many states, like in New York City, for instance, you don't have to go far to move to Connecticut. It's right there, and anyway, so a lot of the really rich people live in Westchester County, right next to Connecticut. So they could move over there. Anyway, So, I think in my own personal opinion is that many, I hope most of them would stay, but others might just say, I'm going to go. And I have to tell you, when I've spoken with patients in Vermont, so everybody in Vermont, we're a high tax state, and everybody knows that. And I actually have had many patients who are not super wealthy, but, who are comfortable, who said, well, I'm going to leave Vermont when when I retire in a couple of years, and I'm not staying because of the taxes. And I don't know how many of them implemented that plan, but many do. And if you look at where people go in retirement, it tends to be to lower tax states. And those, and people over age 55 have the vast majority of the wealth in the country. It's not people your age, those of you who are interns here. So, I worry about people who are wealthy or just kind of taken off to avoid paying taxes, just like their money's being shipped to these tax havens abroad. So, I'm going to switch topics just for a second and get back to the issue of reducing state payments. Now, uh, by the way, I want to also address the fact that you could say that wealthy people, if we had nationally based single payer reform, would they leave the entire country? And I just want to respond to that idea that I think some probably would. But to leave the United States and become a citizen of another country is a bigger deal than just moving across the Connecticut River from Vermont to New Hampshire, if we try out one of these schemes. It's just a bigger deal. And yeah, some people are going to do it, but I think it'll be a much, much smaller percentage that might choose to exit a state. But anyway, what is it that's special about state budgets? And let me just look at this slide. I'm covering it up. So let's look at healthcare inflation in Europe, in the Eurozone, and in the other developed countries, assuming this slide is ever going to happen. There we go. So what's going on is that in the United States, we spend more money than the other countries. And I've shown this slide, at least we're now into the third time, because this is a slide that demonstrates that the United States is a huge outlier and is becoming increasingly more of an outlier every year that goes by. We're spending way more, much higher health cost inflation rates than this large group of countries in the OECD, mostly Europe, Japan, Taiwan, those countries. And notice, though, that the main reason I'm showing this now is not that the US is a bizarre outlier, but that this slope is positive. And the difference between the country of France or the country of the United States and each individual state in the United States is that every state has to balance their budget every year. And if they don't first of all, 49 of the states have a law that says they have to balance their budget. And the other one, which is actually Vermont, has always balanced their budget because they know what happens to the state's credit rating if they don't balance it. Their interest rates on whatever bonds are going on bonds to support road construction and other costs that states face, that those interest costs are going to go up, and that every year they're going to have to pay more in interest costs to their bondholders if they don't keep their budget balanced. So even in Vermont, we balance our budget as the other states have to. And this curve that you're seeing in the OECD countries is a real problem. In every one of those countries, they're not reassured by the fact that they're so much better than the US. This is a real problem. And every year they're faced with this decision to either tax their citizens more or throw it on their debt. And as nations, they are allowed to have debt, disadvantages are big in having a big dad, and we have a big one now here in the US nationally, and it has implications. It tends to raise interest rates and threaten your economy for a variety of reasons. But anyway, so this, if this happens to a state, they can't just throw it on their debt. They have to raise taxes. And so each year that goes by, the state-based programs are facing this little problem that no country in the world has been somehow able to successfully face down this inevitable increase in health costs, presumably due to more expensive technology and drugs replacing older ones. So this is a real problem for state-based reform, and I would like to hear advocates of state-based reform address it. Now, this is the explosion that I'm just talking about, that this inflationary tendency of health costs uh, collides with the balanced budget requirement. And if we do increase taxes, are these folks really going to want to pay more and more each year, more than the other surrounding states? So many Americans believe that healthcare should be a right of citizenship. I personally agree with that. But we don't have that in the United States. What we have instead is people going bankrupt due to healthcare costs. That's what we have in the United States. And half the bankruptcies in the United States are results of medical or have medical contributions. They accumulated medical debt from inability to pay the premiums, the deductibles, and the co-pays and co-insurance they face, and just don't have the assets. Now, for someone who's very poor, they're not really likely to move from their home. First of all, it costs money to move. And secondly, if they qualify for welfare in one state, they'll maybe qualify in another state, and they're just trying to get through their lives. Many of them are never going to have a favorable credit rating. So if they show up at the hospital and their net worth is negative $30,000, because they're in debt and they have no hope of paying off, that's a big problem for them. How are they going to send their kids to college or whatever? They can't just go to a movie or a Broadway play. That's not happening. So dire poverty is a major problem, but I'm not thinking that those people are going to flock to the first state that has state-based reform. I'm worried about the middle class. Because if you're in the middle class and you've been saving for your kids' college education and you've been trying to pay off a mortgage, but you don't yet own the home because you're paying the bank, and you're just trying to build your life. Maybe you're trying to pay your debts left over from medical school. You've got all these expenses, and suddenly someone in your family develops a major illness, an expensive illness, where the drug by itself costs $120,000 a year, and you're paying 20% co-insurance with your, typical insurance, and suddenly you're facing expenses that are going to ruin your family's finances. You might want to be able to send your kids to college, and you might say, well, they got universal health care in state number one. I won't have to pay anything more than the usual tax rate in that state. I'm heading there. And I think that that would get publicized. Other people would then realize that this is an option, and they would be able to protect our assets and investment, maintain a credit rating, and not go bankrupt. And this is on the tab to be financially unfavorable for the first state. Now, if 50 states had state-based plans, that wouldn't apply. It's only the first state or two where it would become an issue. So I worry about this. I hope that the advocates think about this too. They could do something about it. They could have a pre-existing condition clause. Say anybody who comes into our state, if you got cancer, we're not paying for it. Kind of nasty, but they could do that, or say you have to live here before 3 years. Now think about that. What if they said you have to live here 3 years before you're covered at all, even can even participate in it? But then when you talk to the doctors and ask them, well, what are your administrative costs like? Because, we have this state-based system and we're trying to decrease your administrative costs. And the doctors say, well, we've got all these people who moved here who have all these other insurances because the state-based plan doesn't kick in for 3 years. So now you're undermining your effort to reduce administrative costs. So that's an issue. So the strategies to deal with what I call medical immigration, could be problematic. Now so far we've talked about the relentless inflation, which is a big problem. The fact that additional very sick people might add to your state's expenses. And now I want to go back to talking about getting all the other money from wherever you can to decrease the magnitude of the tax increase that your state is proposing. And the obvious way to do this is to say, well, what money is already coming into our state? Now let's look at when we talked about cost control last week. We in a single payer system like Taiwan and Sweden and many other countries that have single payer systems, they have very low administrative costs because everybody's in the same system. And you have very comprehensive coverage with minimal or no copays at all, and certainly no deductibles. So the back office and a doctor or a hospital, they have almost nothing to do. They submit the bill. And the other thing is they're not denied. The denial rate in public systems is incredibly low. Yeah, if you submit a bill for a prostatectomy in a female patient, hopefully their system would find that and say, this looks problematic. But, in general, you're not going to get the flack that we have in our current system. So these are areas of major, major cost control in single payer systems. A state could use, a country or a state could have single software that everybody gets and is developed by the nation or state and is given to every provider. They've done that in Alberta. So this could be done. And I would hope that any state that's creating a single payer system would have that ready to go by year one, because in year 1 and 2, they may have very high expenses already and the plan may already be breaking down. And then they might want to decrease prices. But even if a large state like so if a small state like Vermont says to a pharmaceutical company, well, in a single payer system, we have all this market power because we're buying drugs for every single person in our state. And, a pharmaceutical company would say, well, you don't even have much of a population there. Why would we do that for you? We're not doing it. Okay, so let's say California tried it. They have nearly 40 million people. Okay, California, you want to pay lower prices, but we think that if your state-based plan succeeds, that this may go national, and then our profits are really going to drop. So we don't want this to go national. So we're not going to give in at all. You're going to pay the same damn prices, and if you don't like it, then lump it. So I don't know how well California will do if it actually tries to create a single system for their entire state. So anyway, these are all issues. You could try to have a state-based recruiting system, and that would work, and they should do it. And I hope that when these state-based reforms are proposed, if one of them actually gets enacted, that they'll have that ready to go on day one, because they could save maybe, 0.5% of their medical costs. And they could do something about malpractice costs. Yeah, it's only 1%, but every 1% you can knock off your taxpayers, you should do. So if you do get involved in state-based reform, make sure they're actually trying to save money for their taxpayers, or the whole system is more likely to face the collapse that I worry about. Anyway, so work on cost control and have it ready to go. Don't just wait around and say, oh, single payer system saves so much money. We don't need to do anything extra. Yeah, you do. Anyway, so let's look at the out-of-state sources of funds that could come in, that do come in the current system. So these are being used in the dysfunctional system we have in the United States now. Okay, so in the state of Vermont, from the federal government itself, when somebody goes to the University of Vermont for cancer surgery, they may be in the Medicare program, and if they are, then much or all the money will come from an external source, CMS in Washington. That's who's going to pay most of the cost. So that's an external source of money that we're very dependent on. And when the state's going to try to extricate itself, it needs that money. That's a lot of money. Secondly, there's the active military. When they seek care in Vermont, they use their own system, Champus, or I can't remember the name, began with a T, whatever. Anyway, so there's an insurance program for the active military. And in Vermont's case, we have a lot of military here. And, many states throughout the country have as much as a couple of percent of their population in the military. So they have their own insurance program and they present their card. So is the state going to just say, well, we're just going to treat the military and the taxpayers of Vermont will pay for it. We don't want that money from the federal government. Well, okay. So now you're adding a couple percent to your bill. And then there's the veterans. We still want the money that goes to the VA to support our healthcare system. And I have to tell you, a lot of veterans go to the VA because they can't afford Medicare supplemental insurance. And now they won't have Medicare supplemental insurance because they live in the state that's got this reform. So they can just go to their local doctor. They won't have to trek off to the VA, which can be a long drive. So now the veterans could get treated in the regular healthcare system, and the state taxpayers will pay for it rather than the federal government through the VA system. So a lot of veterans may try to seek care in the state, and why would we refuse that? We care about our veterans. Then there's the federal employees, the postal workers, and the Transportation Security Administration, the federal judiciary. So there's all these federal workers, they may be a couple percent, and they bring in this federally covered insurance, and they all have unions, and they negotiated for their coverage. And are they going to really want to participate in a state program? Well, I guess they might, and they might not. But we need all that money, or are we just going to pay for all of them out of the state? Have our taxpayers pay for all those people. So this stuff needs to be addressed, and I haven't been hearing it from the supporters. For each of these groups, every little percent that you're not going to deal with, and you're not going to make sure you get that money, it's going on to the taxpayers of state number one, whatever that state is. So you need all this money. And you can get the money by billing them the way they're used to being billed. But if you're going to do that, then each doctor's office is going to maintain these massive billing departments like they have now, and you're not going to reduce administrative costs at all. So this is your choice. Are you going to keep using the systems that each of these programs has in place and do nothing about your administrative costs? Or are you going to do something and say, we just want that Medicare money unconditionally. We just want you to just give us the Medicare money. You can actuarially predict how much that's likely to be. Okay, same for the military and the veterans, and they could just give us that money. Is the Trump administration going to want to do that? I don't think so. I don't think this is in their scheme. I don't think this is what they want. They're getting huge campaign contributions from, the groups who oppose single payer reform. I don't think this is going to fly for a minute. And If a state tried to do it and then a conservative government were elected, I think they would undermine it. Now, the same thing goes for the private sector. This retiree health coverage from out-of-state sources is an issue. So my personal friend, taught her whole life in Connecticut. She worked for a school system, and they have retiree health coverage. And so they send money each time she goes to get medical care. They cover the 20% coinsurance that Medicare doesn't pay. And if Vermont says to them, well, statistically, this is how much this individual can expect to cost in a given year, just send us the money in advance. They're going to look at us and say, no, we're not doing that. You just send us a bill for each little service. That's what we're used to doing. Okay, so we could do that and not reduce administrative costs even more. And then what about all the people who come up here to ski and they're not really very good skiers? So they break their femur, they break their tibia, because and they show up at the hospital. I used to work at a hospital, as a hospital it's right near Okemo, one of the larger ski resorts. And we treated these people all the time. And we viewed them as like the golden goose, the goose that laid the golden egg, because we were going to get billed. And, a lot of them had good insurance. They're wealthy enough to come to Vermont and stay in the little chalet and whatever. So they had, quote, good insurance. And we could bill that. So are we going to bill that in the new program? And we have many employees who work over at Dartmouth because it's right across the river from Vermont here. And so they go to Dartmouth and Dartmouth pays us if those people who live in Vermont are going to a doctor in Vermont, then the Dartmouth plan pays that doctor, right? We bill that plan and we get paid. But now, if we have a state-based system, the employee would say, well, Vermont's offering me $500 to refuse their insurance, which has some copays. Whereas if I just take the insurance as a Vermont resident, why would I not? There's no copays or deductibles. So, I'm going to refuse the Dartmouth insurance and let the Vermont taxpayers pay for my care. And Dartmouth's suddenly off the hook. Now, UPS and many other companies pay their employees $500 or more a year to refuse their health insurance. That any UPS employee who refuses the offered health insurance through UPS gets an extra glob of cash. And so any out-of-state company that does that, their employee is going to be really tempted to take the state plan and stick with it with this great coverage. So you've got all these companies who are like Walmart and UPS and FedEx and many, many companies who have a national plan. Usually they negotiate with Aetna or United Healthcare and they come up with a deal. They get a better deal from those companies. And then they provide coverage through that plan for all their employees, including state number one, whichever it is, that those employees can get coverage through UPS or this company governed by this multi-state law called ERISA that basically says that the state cannot regulate a company that's self-insuring, which is what Walmart is doing. They're not part of any other risk pool. They have organized the Walmart risk pool with all their employees who take their insurance. But now let's look carefully at Walmart. Walmart has many employees who refuse the insurance, so they're not paying for those people. And then the employees who accept the insurance, they're leaving them with a portion of the premium to pay, with copays and deductibles, not adding up to such great insurance. But that's what they're offering. And now what you're saying to Walmart is, well, you're a rich company, our state now has a state plan. We want you to stop offering your insurance to all your Walmart employees here, and you just pay us the large amount of money we want to tax you. And that's what you're saying to all these multi-state companies. And even to intrastate companies within the state, they may feel they're doing better with their existing system and they may lobby against this change. So the, it turns out that 1 out of every 6 people in Vermont, and I think the statistic is similar in all the other states in the country, a substantial portion, around 15 to 20% of people in any given state, are part of these big companies like Walmart. That's who employs them. And so you need that money and you got to make sure you get that money. So if an advocate for state-based reform says, well, we're going to get an ERISA exemption, well, be prepared for a real battle because they're going to fight you and they're not going to want to pay all the money that they really should be paying, these multi-state companies. And Anna, do you have a question?
Yeah, talking about this just made me think what would happen to private equity owned hospitals that have hospitals across multiple states. So if one of their hospitals in a state that adopts a state-based universal healthcare reform, obviously their revenues would drop. They wouldn't be able to, pay off their debts. And then how would that affect the other hospitals in other states that didn't adopt it? Like, would they lose employees? Would it put more pressure on the hospitals in other states? I'm just wondering if that's
I
another
think I'm not
topic.
understanding. Do you mind restating your question? I just didn't quite.
Yeah, so when I think of private equity owned hospitals, I'm thinking they're trying to maximize revenue. So um, in this kind of a system, how would their reimbursement rates change? And I'd assume they would decrease, and then they would have difficulty increasing their revenue or gaining enough revenue. And then if that happened in the state that developed a or a state-based healthcare reform, how would that affect the hospitals that private equity would own in other states?
Okay. So, as is typically the case, I'm going to change your question and answer the one I change it to. Uh,
Okay.
I always do this. You find I'm not the only one. I'm going to expand your question and say, and create the question, are we going to pay the hospitals enough so they can do their job, regardless of their ownership structure? And if they are part of a multi-state hospitals quote system, regardless of who owns it, then we could be stressing them. And if they're really losing money, whether they're a private equity, one of the private hospitals a private equity company may own, or whether it's part of HCA, the national one, they may just say, well, this is an unfavorable operating environment if they're not getting enough money. But let me say, I'm not in this talk, I'm not going to spend a lot of time on it, but okay. So if you look at my proposal, for instance, to use a single software system given to every hospital free of charge as a cost control strategy, what that cost control strategy is doing is taking costs out of the system entirely. I've also proposed negotiating against drug companies to lower their prices. In that case, we're not really taking costs out of the system. We're not changing the amount of money the drug company has to spend to produce the drug. So those are two different strategies. One is to just regulate a price and say to a pharma company or a hospital or a specialist, a physician specialist, we're just saying to them, we're not really getting rid of any of your costs. We're not giving you software free of charge or doing any other thing or reducing your administrative costs. We're just going to pay you less. And so, in other words, regulating prices. Right now, we found that our largest hospital in Vermont appears to have unusually high administrative costs. And so there's a strategy now just to simply pay them less. We're not really getting rid of their costs, but we're kind of assuming they're going to do it on their own. So this is called forcing. a forcing strategy where a government kind of says, we're paying less, we think you can handle this and still make a profit. So when a company's making excess profits like pharma, you can just say, we're going to reduce your prices and we think we're still going to be able to buy your product because you're still going to make enough profit. So if you use pricing, lower pricing to go below the private equity company's desired profitability, yeah, they'll probably withdraw from the state and then, that could create chaos. But, I've expanded your question. So what about not-for-profit hospitals who aren't even part of a system they're existing in a current system, there's a certain amount of cost. And if you're going to use pricing as a tool, just say we're paying, for example, in New York, I think they're going to pay something like Medicare plus 10, the Medicare rate plus 10%. But if the hospital is used to having privately insured patients who insurance companies are paying a whole lot more than what Medicare pays, and suddenly that's gone, the revenue stream is going to go down and they're going to have to, it's a pricing, a forcing strategy using lower prices. And so will those hospitals be able to continue operating? And if they're already generating huge profits and surpluses, it'll work. Your pricing strategy will work. But if they're marginal, then it may not. So pricing is sort of a forcing strategy. My preference when I'm talking about cost control is to take costs out of the system entirely. So a provider, when it has multiple insurance companies to contend with, it has to pay the employees who are contending with them. And if there's now a single payer with comprehensive coverage, you just need fewer employees. You can eliminate most of your billing department. So I like to take costs out of the system, but sometimes a pricing strategy is a useful way to control costs. And if you're going to be aggressive with that, then these private equity and multi-state companies are going to no longer make money or even lose money operating a hospital in your state. And it either would create a crisis where the hospital might close, private equity would just shut down that hospital and get rid of it one way or another. So I hope I answered your question. And anyway, continuing on private money. So what about an older person who's a snowbird, who spends 7 months a year in Florida where he or she lives, and then comes to Vermont or another northern state that implemented a state-based plan. They come to Vermont, they've got a Medicare Advantage plan through Florida, and suddenly you're going to say to them, well, you're going to say to your state, well, we don't want to bill because then we have to recreate our big billing department, or are we going to build our Medicare Advantage plan? In which case we haven't gotten rid of our billing department. So what I'm getting at is that the entire edifice of hypertrophied billing departments, which is what we have throughout the United States, it's going to be a big fight with multiple payers going on here to try to reduce administrative costs. I don't know if these advocates for state-based reform are working on the entire list. But a lot of states, another one, we take care here at our university hospital, it's right on Lake Champlain, right across the lake from the Adirondacks, where it's a very undeveloped area. And so most of the people in the Eastern Adirondacks, when they need specialty care, they go to Burlington to get their specialty care, tertiary care center. And are we going to not bill them anymore? We have to bill whatever their insurance is so that the UVM University Hospital can get paid. So there's just all of these groups. If you start adding it all up, it's a whole lot of people. Tourists, what about them if they get sick while they're coming to Vermont to experience our beautiful mild summers? So we got all this money we need to bill for when these people use our healthcare system, and that's most of the money. So Vermont taxes, right now are not paying for any of that stuff. And the question is, are our taxpayers gonna start paying for it? And if so, how are we then gonna reduce administrative costs? And there's a whole lot of negotiating that's gonna have to go on with the federal government to force the private sector to cooperate and to get all these programs, the postal workers, military, and the Medicare people, supplemental and Medicare supplemental insurance, that's got to go. All of this stuff. Got all these people who are paying our providers now, and it's complicated and ridiculous, but it's what we're facing. And it's cheaper to bill them than it is to just throw it on the Vermont taxpayers. So, the question is, we're going to get enough of a waiver, and can the federal government really going to do all this? Same thing with Medicaid and reducing. And right now, you have to show that you're doing lead screening, and there's a whole bunch of stuff you have to demonstrate. We would still have to do all that. I don't have a big problem with it, but it's there. You have to, Medicaid has a bunch of requirements, and we'd have to spend the administrative cost to indicate that we're cooperating. We already talked about the Medicare Advantage, that suddenly Medicare Advantage wouldn't exist. And keep in mind, the Medicare Advantage thing is actually an unusually big problem for state-based reform because the federal government is overpaying them, leaving the Medicare Advantage people, the people who are in Medicare Advantage plans, with really low premiums. And if they don't get sick, then they don't see the co-pays. So they're getting a great deal. And if they're going to be forced into the state system and be taxed, that tax may be a lot higher than the premiums, which are inappropriately low because the federal government is overpaying Medicare Advantage plans. So that's a particularly hard sell for this state-based system. And I already talked about retiree health coverage, Medicare Advantage, I just talked about. The same thing goes for Medicare D. It's a big bunch of federal money that's covering elderly people's drugs. And there's a premium, which is, whatever it is. And so, if they're in a state-based system, they get penalized if they withdraw from Medicare D. So that's an issue. What if are they going to be considered penalized because they didn't pay into Medicare D because now they're paying taxes in Vermont or whatever the state is, state number one is. So if they then move out of Vermont and try to get Part D coverage, are they going to be penalized? So this is administratively really complicated. So military, we talked about. Other federal employees, we've talked about. Care provided to out-of-staters, we've talked about. And again, these out-of-state employers, they're going to have a financial incentive to try to get their employees to refuse the coverage and let the Vermont taxpayers pay. Now, another little issue is the out-of-staters who come to work in Vermont. Now, we got to tax every employer and every person in the state to fund this system, this state-based system, and we would do that. So a Vermont employer can say, well, my employee actually lives in another state. He's just working here in Vermont. And my company's online anyway, so I got people working all over the country. So if we then say, okay, so you're only going to have to pay for the Vermont employees' coverage because they're in the state, but these other people who live in other states, you don't have to pay for them. Then they're going to have an incentive to not hire people who live here. So we can't let that happen. So we have to force these employers to pay for everybody. Now, they may already be doing that in whatever private insurance they may or may not be providing, but we don't know that. Now, I'm just saying they're not going to get a deal. They're going to have to pay in just like all the other employers. And it's possible that their insurance is crappy. So the point is, you cannot jeopardize these external sources of funding. And here's the long list of groups that require billing processes that are their own, that are unique. Whether it's the Indian Health Service or whichever it is. So, and again, these internal sources, the existing internal sources would be used. That's what Vermont pays for its Medicaid program and what our own hospitals are paying for their employees to get coverage. But that's not the majority. The majority of the money is flowing from these external sources. So you got already internal sources and the external ones, and I'm worried about the external ones. I'm worried about the internal ones too, because you still have a PR effort there, but that's a whole nother matter. Okay, so the two key levers I talked about, single software, all these other things, getting rid of staffing agencies to reduce costs. But the big ones are administrative spending and bulk purchasing, and I think both will go very poorly. And now you got the PR aspect of this, that the higher income earners who are paying a premium, a tiny portion of their income, are they going to want to do this? And presumably you're going to use a pricing strategy and not pay urologists and anesthesiologists so much, because every extra dollar you pay is a tax increase on the tax levy for your citizens. And people are healthy and building up a health savings account. They're going to lose out financially. Medicare beneficiaries who pay little for their Medicare coverage and their Medicare Advantage plans, you got a PR effort with them. And businesses which provide crappy coverage or no coverage at all, they're going to get taxed somehow. And then unionized workers who's negotiated for great coverage, they think is stable. Now, we talked about all this in nationally based single payer reform, but you got to remember that it's one thing to decide you're going to leave the United States if the whole country is going to have a single payer system, which they may grow to like later. But one little state, people could say, well, it's looking like I'm going to pay high costs, and how many years is it going to take for the other 50 states to adopt a program or for it to be imitated nationally? Anyway, so all these groups, healthy people if they're well off, wealthy people if they're healthy, they're all generally going to do worse with good insurance, and they don't know that they're going to get sick that year, and they think they won't. So you can have flack from these people. I already talked about this. And this menacing inability to control long-term healthcare costs, menaces every state. So I understand the impatience with the decades and scores of years it's taken to not have nationally based humane health reform. But I don't think you resort to a state-based scheme that's going to collapse. And failure of an attempt at state-based reform will be disastrous for the national effort for Medicare for all. Look what happened in Vermont. We're the only state in the country that actually enacted legislation. And here's the ceremony. On the left is a doctor who worked harder than anyone to enact a state-based reform, Deb Richter. And there's the rest of them are mostly politicians who got it enacted. They were proud of themselves. This is actually a picture that was on the Washington Post newspaper, because appropriately, this was a major event in the history of healthcare in the United States. Our governor, his name was Peter Shumlin, signed the first single-payer healthcare bill that was going to start out with a study. What were the financial ramifications? How would they go about doing it? And then was going to try to go ahead and enact this system. 3.5 years later, December 17th, 2014, here's the headline from the Washington Post. Vermont ends push for single-payer healthcare. It was never enacted. The study was done, and it was published in 2014, and said that there would basically be minimal administrative savings. They did not anticipate lower prices vis-a-vis pharma or anyone else. And so it looked to be financially unfeasible. They couldn't deconstruct all the administrative costs or deal with all the other external sources of funding they would need. So this is what what actually happened. And here's a subsequent article, Washington Post again. This was covered in the New York Times and in most of the national newspapers. Why Vermont's single payer effort failed and what Democrats can learn from it. Now, I just want to say, when I saw this headline, my blood boiled. And it wasn't because the effort didn't fail, because it did fail. But notice the characterization, that little adjective there, single payer effort. But Vermont couldn't really offer a single payer plan because they had to go through the administrative processes for most of the lists that we just went through in this talk. They were going to have to bill Medicare Advantage plans, and they were going to have to bill for the Postal Service workers and everything else. So this was not a single payer system. This was a state-based universal health plan where everybody who's uninsured was going to come into the plan. The Medicaid people were going to come into the plan. And this occurred during the Obama administration. Obama wouldn't grant the waiver to bring in Medicare. Think about that. I mean, imagine what George W. Bush or Trump might do. So this was not a single payer effort, even though all of the press outlets called it that. Many of the advocates kept calling it quote, single payer, which it never was. And that's what everyone thinks of it as, a failure of single payer in the United States. That's what they're calling it, making single payer into a noun. Single payer failed. So the problems, to summarize, are the tax increase, the fact that nobody in Europe or elsewhere seems to be able to control healthcare costs, and states have to balance their budget, some threat from middle-class people who become suddenly ill, facing cancer treatment for leukemia or some kind of cancer, who might migrate to the first state, and then challenges with cost control if you're not working really, really hard at it. Anyway, so I think that's all I got here. So anyway, so that's my worry. And at this point, we can open it up for discussion. And again, I'm unhappy. I'm unhappy that I feel this way. I don't want to feel this way. I want to feel the other way, but I don't feel that way. Go ahead, Zach.
Yeah, I don't. This is the first time we're getting into the weeds of like what it would take to implement a system like this. And I know we're focusing on a state level, but it's as someone who maybe isn't the most optimistic about the potential of implementing one of these plans, it's just reinforcing ideas of like policy trap, and there's just so many like barriers to implementation of these plans that I still don't even know where to start aside from like a maybe even creating a new institution in the United States would be required to create this level of change. I just get more discouraged, unfortunately.
Again, I want to respond to your pessimism. I don't think this is going to happen by itself. I don't think convincing Obama, I mean, you can't even convince Obama, much less, the other Republican candidates for president. I think they will move when the people make them move. And the Trump's election and re-election are part of a populist movement against basically many people losing middle class status and or feeling like their children's opportunities won't be there. And they've misplaced, from my point of view, they've misplaced their energy into blaming immigrants for their plight and Black people who, are supposedly given so many advantages, and finding external sources of blame when social solidarity would get them so much more. But I think that the shift, I just feel you're too mired in the Reagan era and now this nonsense that's replaced it, the Trump 2, era, which I don't think will last 40 years like Reagan did. I think this is much less stable, and there is going to be social change. What Trump is not solving very many problems that people face. And I don't think it's going to take more than 10 years for people to figure that out. And then the question is, since the previous thing didn't work either, the Reagan approaches, I just think that there is social change. And yes, you haven't seen it during your lifetime, but it happens. And I mean, the atmosphere, I still remember this, I was very young, but the atmosphere in the early 60s around the victories of the civil rights movement, it was an excitement. And actually, some of what the 60s kind of deteriorated into was because they wanted so much and they weren't in the, and they couldn't quite get the change as quickly as they wanted. But so much was accomplished nonetheless then. I mean, elderly people could not get medical care before that decade. This is an enormous achievement. Back in the 30s, Social Security was enormously important. These are major changes by themselves, each of those. And, the other things, all that got done. Nixon was in power when the Occupational Safety and Health Administration was created to monitor worker health. And it was in place for all of these years. It survived the Reagan era. And it's only in the deconstruction of Trump that we're seeing it attacked. So these institutions, Nixon was forced to sign these laws because it was the spirit of the society is that we were going to take care of our people. There was enough social solidarity left. And then the ideology behind that was changed to create the Reagan era. But the Reagan era did not start in 1776. It started in 1980. And yes, the political right worked on the ideological underpinnings of it and the propaganda effort in the 60s. But nonetheless, it's you don't know that this is not stable. Even if there were no Trump era and we were still in the Reagan era, I would still tell you it's not going to last forever. But Trump is so restive and unafraid that he's exaggerating all the tendencies in this country to not take care of its people and to have so many people left out to dry. And I just don't see it as being stable. Anyway, well, I'm sorry to be preachy, but I just think you need to be less confident about the impossibility of change. And and let me just say more. I'm sorry to take up so much time, but it's an important question. So if I felt that my effort in the next 2 months would make all the difference and would immediately lead to single payer universal health care, I would drop every other thing I'm doing. I'd get someone else to take care of my dog. I would stop going hiking. I would work on that tirelessly, but I'm not that optimistic. I'm optimistic enough to devote a number of hours of my life to working on the movement for a humane healthcare system. And I devote a certain number of hours. The rest of it goes to my family and to just going to a play or doing things that are fun or, whatever I do, But I'm optimistic enough to say that I'm going to devote a certain amount of time to this. And I care, and I've seen too much suffering to not take the chance that this can really happen. And I believe that when there's a social movement that becomes powerful to say they want a government that actually does something to help its people, like you're going to learn about with Sweden and with UK, even in their healthcare system, that there's no reason we can't do this as well and figure out ways to articulate it. Sorry to be so preachy. Go ahead, Caitlin. Caitlin muted? Oh.
Thanks. First, I want to say Can you hear me? Oh,
Yeah, I can.
okay, sorry, my Wi-Fi, I think it's a little finicky. But I just want to say thank you for your words. I feel like definitely like as we all are growing up in kind of the age of Trump, it is kind of hard to have hope sometimes just because we haven't really seen what things were like before. But I do think it's really reassuring that you have hope. And I think I do agree with you. I definitely can tell there's a lot of social unrest, and there has been. So I feel like it's definitely going to reach a point, like a breaking point, and maybe it does take a big event or a collapse in order to bring about kind of radical, non-incremental change, but I do feel like we are on that path. But I do have a question. So, do the supporters of the state-based universal healthcare reform, do they see it as a stepping stone to um, to the national health program, or do they think that the state-based solution is better?
So we're going to have at least 4 people coming this afternoon. I'm including Betty, who support state-based reform. And so I can let them speak for themselves. But to be honest, I know many people. I don't know a single person who's working on state-based reform who doesn't want, hope, and believe that a successful effort would not lead to national reform, and they all pretty much would support nationally based reform if there were a way to get there. They just feel that it can succeed at the state level and then serve as a role model for the rest of the country. And then as I've said many times, the reason I'm thinking that a broad social movement should start with healthcare rather than like subsidizing rich people to buy electric vehicles, some policy like that. That's not going to lead to so generalized population ecstasy with progressive reform. A single payer system that really takes care of people when they're sick. That's what the movement should start with. And, it would, if a state could create a successful state-based system, it would be popular and then presumably extend to the rest of the country. Did that answer your question? I'm not sure it did.
Yeah, it did. Thank you. And then I also have one more question. So I'm wondering how the state-based universal healthcare effort in Vermont compares to what's going on currently in Oregon and their kind of efforts to move towards that. So I'm just wondering what you think about it because I don't really know much about it.
Right. So I believe that you've mentioned the right state because we have people from 3 different states coming this afternoon, and one of them happens to be Oregon. So you'll get to hear about the Oregon effort.
Thank you.
By the way, Dr. Chi, who created that 20 or 30-minute video, if you go back and watch his presentation, he doesn't deal with a single thing I talked about today. None of them. And I'm not criticizing him. He helped to design the successful Taiwanese healthcare system. And he talks about the basic steps in the analytic framework to develop a successful state-based system. But my talk just now was basically a talk dealing with these little annoyances. That's what I think of this talk. It's as a framework, I totally agree with everything Dr. Chi said and what you're going to hear from the fellow from Oregon today. I just think that there's all these little things which they kind of have to deal with to be able to call it a single payer system without expending too much administrative costs to get there. And then I worry about the price negotiation, especially with pharma. But anyway. So anyway, but Oregon will speak today, so you'll be able to get that answer. And again, I'm very sorry to be depressing. Not my goal. Zach, go ahead.
Yeah, I just wanted to point, when I was listening to this presentation, I felt like all of these things were not just like small hurdles to state-based reform, but like they attack the things that we've centered as like the most, like the reason we should have single payer, of like the cost control strategies of like it prevents significant administrative cost reduction. It prevents the ability to negotiate with a single like payer pool. Like those are, I feel like, the two biggest cost saving methods of a single payer system. And from your presentation, it made it seem like there's almost no faith that we'd be able to achieve those things because we'd still have to deal with some sort of, even if we do have a single payer and Medicare, the VA, everyone pays into it, they still have to, that single payer would have to bill and get payments from all of those. And then like I do share your sentiment that like private companies aren't going to want to negotiate. I think they're going to want to set a precedent. If you try to set up a single payer state, we're protecting our profits. We're not even going to, it's like America doesn't negotiate with terrorists, is how I feel like they would do it. So that's why I was largely pessimistic about it, because it did present as like these are just unsurmountable barriers. But is that not what you meant to present it as?
Okay. First of all, I think a nationally based single payer reform enacted in the United States, pharma would have to negotiate because there's 341 million people here. It's not even a choice. But I have to tell you, and I feel confident that if it's fewer than, I don't know, 10 million people, they definitely won't negotiate, and not in the United States. They'll hold the wall. I don't feel 100% sure that California couldn't sneak some stuff through. I don't know that. I mean, you got to remember that for the most part, pharma is an oligopoly, otherwise known as cartel. And unlike monopolies that have somewhat predictable behavior and the free market, which will come to a price through the magic of the market, this is oligopoly stuff, cartel stuff. And cartels are a little harder to predict. A disciplined cartel is where nobody gives in. And they would not, none of the drug companies would negotiate at all. That would be a disciplined cartel. And then at the opposite extreme are cheaters, the ones who they want to have a lot of sales, so they'll cheat and sneak their oil to some country, and they were going to set their oil quota somewhere. Anyway, so that could go on where one of the pharma companies might negotiate, but it would have to be a pretty good deal that they would get, a big volume discount. It would be a bigger state. So I'm not 100% sure, but as a group, there would be a big effort within pharma to not negotiate. And this is part of the motive of why a lot of the state-based reform supporters want it to be multi-state. But I don't know. My experience with state government is for them to cooperate with other states in their area or whatever is a big lift. State governments have their own laws, their own calendars, their own ways of doing things. And for them to form, a multi-state group for what amounts to a quarter of their entire state budget, and losing that authority, giving that authority up over how much money they're going to spend on their Medicaid program and covering insurance for the state employees they cover, to just give that up off to some multi-state pact is not a small lift. So politically, that's actually a tough one, dealing with the other states that they would get into a pact with. But I don't feel 100% confident that a state like California wouldn't find a few cartel cheaters, who might negotiate with them. I don't think it's impossible. I just think it's a little risky, and you don't know in advance how well that's going to go. The whole thing just makes me nervous. It could go. If I saw them take on every single thing on my list, and I saw them doing it, I would be somewhat reassured. I never saw it. Like, are you taking on workers' comp? Are you going to, in other words, people get injured through work in the US, there's a whole separate system to cover that. Separate administrative structures. It could be dealt with at the state level. I just want to see them do it. And the same thing for auto wreck. You get into an auto wreck, it's a whole separate insurance thing. Private auto insurance carriers, you're paying to drive your car, that they would have to be brought in. So it's a ridiculous system we have, and it needs to go. It just needs to go. It's just complex and stupid and complicated, and I hate it, but I don't just know if the state can win this battle. I don't know. I'm just worried about it. So make those people this afternoon do all these things, and then I'll reconsider.